Echo.
Is my screen shared?
Yeah, we can see you, sir. You can go to the full screen mode.
There is some problem or what? Is it coming up?
Not yet.
Okay.
Yeah, that's there. We are there.
Oh, yes. This is the photograph. I mean, I filmed in Mount Blanc last year when I went to ESC. You can see here the paragliding experience. So unless you have a 4D experience, you will not be able to do the paragliding, and you will not do the echocardiography also. So these are my credentials, and this is Mata Pita Guru Devam is the song which is very famous here. So I worship Mata, Pita, and Guru. My father expired last year at the age of 90, and after exactly 1 year, my mother also expired. See, their joy in the face of the mother when I presented her my book. See, that is an enormous joy, and for this you can sell the whole world for this. And this is the song, this is a Mata Pita Guru Dev. So I begin with that. And this is where I started 3D echocardiography. I think Parale would be remaining, will be remembering our PGI days. So this ultrasound waves or echocardiography is nothing but interaction between the ultrasound waves and tissues. And the improvement in MO to 2D to 4-dimensional echocardiography is made possible by this improvement in transducer technology, which you see here. That is the transducer technology which resulted in this. And you can see here, this is the 2D transducer which has sparse array. Only the elements are very little, and compare this to the 3D, you got more than 3,000 elements here. And that is the 3D transducer. It's called as matrix array transducer. And next big advance is the local big data or channel memory, which is available by the C-sound technology and advanced technologies, which are incorporated into the transducer. So this is called as adaptive contrast enhancement. Adaptive contrast enhancement. Thereby you are able to have all these views. So this is the in 3D. In 2D you have only two directions. One is azimuthal plane, second is the axial plane, y-axis. Whereas in 3D you have the elevation plane, which is seen here, the elevation plane. So axial plane, azimuthal, then elevation plane, and then you have got this done in a live manner in real time. So the time is the fourth factor. So that is the 4D echo. So commonly used 3D echocardiographic techniques involve the assessment of LV, RV, LA, and other things. So chamber assessment has become very important used for transthoracic echocardiography, and assessment of the valves, especially the mitral valve, anatomy, stenosis, and regurgitation are easily accessible by the 3D. And now you have the advanced catheter procedures which can be done under 3D echocardiographic guidance, especially percutaneous mitral valve implantation. TAVR, still they don't believe in 3D echocardiography. They want CT for all guidance. But anyhow, if there is a complication in the cath lab, they immediately perform the echocardiographic examination. The other advancement which is of use is the 3D printing and virtual reality and holography. So the clinical applications I can summarize in direct automated evaluation of the cardiac chamber and volumes. So I will spend some time on this. Second is the surgical views of the mitral, tricuspid, and aortic valves, assessment of the regional LV wall motion and direct evaluation of the size of the vena contracta, especially in mitral regurgitation, and for interventional procedures. So the normal cardiac examination, the 3D examination is not different from 2D. And you have got the transducer, which is very small now, unlike the previous day 3D transducers, which were very large. The current 3D transducers are very small and handy. And you do the echocardiography by these techniques: rotation, tilting, and angling. So that is the usual standard positions. So 3D I consider as an extension of the 2D examination, and use the same parasternal views as well as the apical views. In addition, you have the suprasternal and the subcostal approaches. The same planes which are used: long axis, short axis, and other things. But before going to the real 3D, you must understand some of the techniques which are called as live 3D or bird's eye view, and full volume, where the full pyramidal data set is secured, and 3D zoom, which is especially useful for valvular assessments, and the biplane or triplane assessments. So this is the strengths for the live is high volume rate in real time, whereas it is having a small sector size and fast frame rate. And whereas in full volume, it is high volume rate, large sample volume, but you have the stitch artifacts. Zoom is very good for NPS views, especially the mitral valve when you do the transesophageal echocardiography or transthoracic, but it has a slow volume rate. The biplane or triplane views are live biplane or 2D in color Doppler, and it is not full 3D. You must remember this. Color Doppler can be added to the 3D mode. So this is the long axis view which you see here. And what do you comment on the mitral valve based on this single view may not be correct. Here you can see here, see this see that in a single plane long axis you see this as a mitral valve, normal mitral valve, whereas here you see double outlet mitral valve. See, two outlets are there. You can easily pick up just by placing the transducer and switching on the biplane view. And this is the bird's eye view, which is very important to adjust the size and position and views. And you have the controls. You can increase the lateral width, or you can increase it in the elevation plane. So all these things can be possible. This is the full volume. This is the 3D zoom. You can see here, this is the biplane view. And here you see the long axis view. And only in this you can see the surgeon's view from the transthoracic. Otherwise, you will have to do the transesophageal echocardiography to get this surgeon's view, because you cannot view from the LA side. Always you see from the LV side. And this is a coronal plane cut, where you can examine the subvalvular apparatus of the mitral valve. It's very easy to understand these things. So how do you acquire this biplane view? This is the biplane view where we start, and you can place the acquisition box to obtain that, and then go for the zoomed view of the mitral valve. So you see the zoomed view of the mitral valve, the mitral stenotic area. By exactly cutting at the tip of the mitral valve, you can see the quantify the mitral valve area and mitral stenosis. Similarly, you can look at the aortic valve. You can see here the aortic valve, and the acquisition boxes can be placed appropriately, very accurately. You can adjust these acquisition boxes and to acquire the whole of the aortic valve. And this is the 3D of the aortic valve which you have acquired. And so that is how you do the assessments. So now you go for the left ventricular systolic function assessment, which is very important. And especially this is very important for heart failure patients, patients in whom LV dysfunction forms the important component of the risk evaluation. And asymptomatic patients who are at risk for developing heart failure, especially in heart failure. So this is a very important thing. And mostly our interventional cardiologists and regular cardiologists, clinical cardiologists, they just do the echo, and what they do, what is called as eyeballing. Just to say this is ejection fraction is 50%, 60%. So this is very subjective, and it is experience dependent, and there is no standardization here. There is a large inter and intra-observer variability is there. So that is a problem. And second method is the M-mode echocardiography, where the Q formula is obtained. You can see here, this is a cube. And you must know, left ventricle is not a cube, ice cube. So the shape and geometry are wrong. So never use this M-mode echocardiography. This has to be discontinued as per the advice of the American Society of Echocardiography. Then you have got the 2D prolate ellipsoid formulas which can be applied. Again, this is this leads to a lot of problems in the calculation of the ejection fraction. The only good method is the Simpson's method, which correlates with the here. See, it's a method of multiple cylinders. Volumes are calculated and then added. It compares relatively good with the 3D echocardiography and the CMR, but still the number one will be your volume calculation by 3D. Unless you are if you are going to dive, you must know the depth. Without depth, if you are going to dive, you will die. So always remember 3D mode is better. And here the advantage is that you know where is the true apex. The foreshortening is not there, and the segmental dilatation can be avoided. So these are the advantages of the 3D. This is from classical vendor GE. The classical 3D calculation is very easy. I will demonstrate at the end of this. This is by the Philips. We used to do this in IE33, the old and the machine, and now they have got the heart model, which is based on artificial intelligence. They have the heart model. So heart failure therapy is based mainly on echocardiography. And when there is no echo, you will have a lot of problems, and the mortality rate is higher. So with echo, these things are easy. And ischemic versus non-ischemic.
आपको अपॉइंटमेंट वाला नंबर में बोलना पड़ेगा, वो आपको टाइम बताएंगे.
Hello, am I audible?
वो हर मरीज को 20-20 मिनट बाद बुलाते हैं.
And this is the regional wall motion abnormality scores which are possible. And 2D tomographic slicing will give you a better idea of the regional wall motion.
कोई दूसरा बनवा देगा. आप किसको भेजा था?
Regional wall motion abnormality can be picked up very easily when you have this tomographic slicing. So this is a case of dilated cardiomyopathy. You can see the dilated heart contracting, and you can use this for stress testing also. Another important advancement is the myocardial deformation imaging using speckle tracking imaging. So you can have the longitudinal strain imaging, and you can see here this longitudinal strain, where the longitudinal speckle tracking is done during the end diastole and the end systole, and the strain is the percent change in the length, and that is this strain. You can see here. This is the end diastole, end systole. The percent change is -23. So you can have this from the apical 4-chamber, 2-chamber, and the long axis, and also from this is called a circumferential strain, and this is the radial strain when it is coming away from the center and going back. That is a radial strain. And the twisting motion of the apex, it will be counterclockwise twist, and the base will be clockwise twist. So this gives a twist. So all these deformation images can be measured by this, and this is also used to find out the area of territory of involvement. This is the LAD territory. You can see at the anterior septum, anterior wall, anterolateral wall, Inferior wall, inferior septum. So this area is by LAD territory, and this is the RCA territory, right coronary artery. So I will show you in a case. This is a patient who presented with ST elevation. You can see here in inferior, 2-3 AVF and V6 R. You can see that. And this is a strain imaging. So here, this is the, this is the 4-chamber view, this is the 2-chamber view, and this is the 3-chamber view. And here, this is the inferior septum, which is there. You see that that is the inferior septum. This is the inferior septum, this is the inferior wall, and this is the inferior lateral wall. The motion abnormalities are very difficult to pick up in this, but once you place the strain value, you can see the red area is normal and the blue area is abnormal. So this is the inferior septum, this is the inferior wall, inferior lateral wall. So this is a classical RCA territory, and the GLS is around -17, which is reduced. So these are the tomographic slices which show the inferior wall is not moving properly. And this patient was taken for a primary PCI. You can see here there is a very tight narrowing of the mid RCA, and stent was placed, and the patient became the pain was relieved. And this is after the primary coronary intervention. You can see PPCI. You can see the area of the strain abnormality has reduced markedly. The ejection fraction has also increased from 44% to 54%. And this is another case. This is a patient with anterior MI. You can see here. This is a patient with anterior MI, where you can see anterior septum, anterior wall are involved here. So the problems of calculation of ejection fraction are that they are dependent on geometry. They are load dependent, and heart rate, high heart rate and low heart rate may affect. So insensitivity to minor changes. So all these prognosis flattens, so prognosis curves flattens at 50%. So that is the main problem with the ejection fraction. Whereas the strain value gives you added benefit in these patients. And in that strain also you have the added advantage of the 3D strain over 2D strain. Here, 3D strain can be obtained from one apical 6-beat full volume, whereas 2D strain you have to take 3 apical 2D views in a different ECG gated recording. So this is a single beat, whereas this is a beat recorded at a different time interval. And the temporal resolution you can see here. And area strain is the most important advantage. And bullseye map is dynamic, and the most important benefit is that out of plane motion speckles are absent in 3D strain, whereas they are present in 2D strain. So this is the 3D strain. It's a cube which is tracked, whereas in 2D strain it is a speckled dot which is tracked. So that is the difference between the 2D strain and 3D strain. So you can see here the step 1 is acquiring the multi-gated image from the left ventricular apex, and then identification of the left ventricular myocardium, that is the tracking of the epicardium, and then the 3D speckle tracking is done. And in a single beat, you can have longitudinal strain GLS, and this is the calculation of the LV mass. This is the 3D LV strain replacement of the region of interest, and then this is the GLS and the longitudinal strain, which is available immediately on a click of button. Then you have got the circumferential strain and the area strain, which is available, and then the radial strain is also available from this single beat. So the normal values for the 3D longitudinal strain is -18 to -20. Circumferential strain is -20 to -22, and then radial strain is positive strain more than 40. So another advantage is the left ventricular twist. The myocardial architecture of the left ventricle has an oblique double helical fiber arrangement, and shortening and lengthening of the helically oriented myofibrils result in ringing motion of the left ventricle, which is systolic twisting followed by diastolic untwisting. You can see here, this is the clockwise rotation of the base, anti-clockwise rotation of the apex. So this is the twist, and this is the twist degrees which can be separated. You can see here, this is the twist degrees can be measured. You can see here it's around -3 to 8. So this is around 11 here, twist. So in hypertrophic cardiomyopathy, you can see here this patient having a normal longitudinal strain, whereas it's reduced longitudinal strain, whereas it is increased in circumferential strain and radial strain are increased. So this is the basal rotation and this is the apical rotation. So this is called as the left-handed helix. So this is the rotation which can be measured here, the breathing motion, and this is just like squeezing of the water out from a wet towel. So this is easy for this, and the advantage of this is that when you have a reduction in torsion or the rotation, gets bad prognosis. You can see here, this is the apical rotation, counterclockwise rotation, and this is the basal rotation, which is a clockwise rotation. And the difference you can measure. And this measured difference is normally should be more than 7. So that is the normal value. This is a normal heart. Whereas in dilated cardiomyopathy, this rotation is totally lost. It's very much decreased. And this has a relation to the mortality rate. The twist has a relation to left ventricular sphericity as well as the mortality rate. You can see here. So whenever the twist function is lost, the patient's survival rate is very much reduced. This is in amyloidosis with normal LVEF, and this is the case of constrictive pericarditis where it is. And in patients with the subendocardial dysfunction, it is increased actually. So this is the apical rotation, this is the basal rotation, is increased with abnormal relaxation, grade 1 diastolic dysfunction. It's reduced with the pseudo-normalization. It is further reduced when you have a restricted morphology. So the limitations are the concepts that first became familiar to echocardiographers with the appearance of the secondary leaking. But there are several limitations in measuring the rotation and twist. It is only available with one vendor, and it is not available with all the other vendors. So that is the problem with this. And another important thing is the RV function assessment. See, RV, you have 3 portions: inflow tract, apical portion, and then the infundibular. So 3 portions: inflow, apical region, as well as the infundibulum. So in 2D calculation, always it is very difficult. 2D parameters have the advantage of relying on routinely acquired standard views, but the problem is the infundibulum will not be counted. So if you want to calculate the infundibular area also, only 3D can do that. So this is the views which are selected for this. This is RV modified apical 4-chamber. This is the RV focused apical 4-chamber, and this is the regular apical 4-chamber. What is required for calculation of the RV volume is RV focused apical 4-chamber, RV focused apical 4-chamber. And you can see here, this is the RV focused apical 4-chamber, and the 3D image is acquired. You can see here, this is the LV, this is the interventricular septum, this is the RV which is placed. And this is the how to acquire the RV focused apical 4-chamber is you have to slightly tilt and rotate the transducer so that the RV apex is seen. RV apex is seen. So that is the how it is shared. And this is done in very easy steps. First is you have to align the views, then place the tricuspid valve center over the center of the tricuspid valve. And you can see here it is placed over the center in 4-chamber view, then in the RV 4-chamber orthogonal view, and then you have to place the landmarks. Second point is place the landmarks. That is a tricuspid annular free wall, annular septal, then the RV apex. 3 important things. and then RV posterior wall or LV-RV junction, that is the septal attachment anteriorly, and then the RV free wall. So now you have the RV volume, the inflow, the apex, as well as the outflow or the infundibulum, all are seen, and you have the RV ejection fraction calculation, which is spotted immediately around 45% here. So that is how it is easily done. This is one of my study from Leh Ladakh. I went there for studying our young Jawans and the mountain sickness prevalence there. We did the 3D echocardiography study there in acute mountain sickness. This is one of the patients who had mountain sickness, and you can calculate the LV ejection fraction was 52%, whereas the RV ejection fraction was reduced. You can see here 42%. So this study was presented in ESC conference last year, and in the calculation by 3D ejection fraction was more reliable. It was reduced, whereas 2D ejection fraction was not that much reduced. You can see, and we compared with the normal Highlanders there. The LV diastolic dysfunction, the American Society of Echocardiography has revised their guidelines, and there are now 4 recommended variables which are important. Number 1 is E velocity, E prime. This is the tissue Doppler velocity. The septal E prime should be less than 7, lateral E prime less than 10, and average E by E prime more than 14. This ratio is very important. And the LA volume index is 34 ml per meter square, and peak of TR velocity more than 2.8. Why I am saying is that LA volume calculation by 2D is cumbersome, whereas 3D is realistic. And you can, for doing the LA volume calculation by 3D, you have to optimize the LA image quality and then optimize the temporal resolution. And as you know, the LV is, has a different line of angle. You can see the LA has a different angulation. So you have to do specific LA specific views. Selected LA focused apical 4-chamber view, and the image sector has to be narrow. Check for artifact-free visibility of the LA volume, and acquire the multi-bit data set. And then the calculation is very easy by 3D. You can see the set landmarks. The center of the mitral valve center is placed in 4-chamber, apical long axis, as well as 2-chamber. And then you have to select the end diastolic point, the end systole, and then the atrial contraction, beginning of the atrial contraction. So all these 3 has to be marked. You can see here. Set the end diastole, set end systole, and set the atrial contraction. So all these things has to be done, and you can correct these volume slices which are placed there, and you have the 3D volume data which is immediately available. 3D volume data. See here, the LA maximal volume is 104, LA minimal volume is 75, and the LA emptying fraction is 28. You have one more advantage is that you have the volumetric graph of the LA volume as well as the strain volume. See here, this is the LA strain. Reservoir strain is markedly reduced. You can see here it is only 7%, which is very abnormal. LA strain, which is available here. So LA volume calculation, and LA strain. This is LA strain graph. This is reservoir strain. This is conduit strain, and this is the contraction strain. Now, what is important is the reservoir strain. So forget about the conduit strain and contraction strain. The most important is the LA strain, that is the reservoir strain. Total strain should be more than 40, and it should be around 45. You can see here, this is markedly reduced. The strain here is 7%. So symptoms and signs of heart failure, you have to calculate the ejection fraction, calculate the LA volume and LA strain also, and do this functional assessment by the Doppler studies. And this correlates very well with the LA strain curves. You can see the normal LA strain is around 45, When you have a delayed relaxation, it is reduced to 33%. And when you have the pseudo-normal pattern, it is reduced further to 24%. And when you have a restrictive pattern, it is reduced to 10%. So this is the summary slide here. So these are the reference values. You can see here 3D volume, maximal volume is slightly more than the 2D volume. This is there. So the LA volume calculation is very important, and that is the other thing. So I will demonstrate one case where you can just see how this is calculated. Are you able to see the screen? This is the 3D from a patient with left ventricular hypertrophy who had severe systemic hypertension. His BP was 180 by 130. I will show you how this this is Heidi live. You can see here, and you can see the measurements of the LV volume. Is very easy. You can just select the volume, select the LV quantification, and you can do that very easily. You can see here. First is this transverse line is positioned, and then you have to mark then the end diastolic volume. This is the end diastolic volume. You can set the end diastolic volume just by marking 2 points. So you get the end diastolic volume set, and then you can choose the end systolic volume. If there is, if the machine derived tracing is wrong, you can always adjust. You can place the points correctly and adjust for that. So then you go for the volume waveforms. The waveforms may take some time, and then you have the volume measurements which are available. You can see here volume is available, and ejection fraction is immediately displayed. And then you can go for the LV mass also. You can see here mass. For LV mass calculation, you have to slightly modify this. This is the epicardial border which you will have to trace. See that you have to trace the epicardial border, and these 3 cuts you can verify the basal level, mid LV level, and the apical level. You can just see, and then go for the LA 4D strain. This is the strain region of interest placement over the strain. You can see here, and then the strain results can be available immediately. This is the strain graph which is available immediately. So these are all the 3D strain which is which I am showing to you. This is the 3D strain. It may take 1 or 2 seconds, and then these things are displayed immediately. The results can be displayed immediately. See that it is displayed immediately, and you can adjust by segment. You can approve that, approve this segment, and then approve the segment. Only if you think it's correct, you approve. Otherwise, you don't approve. That's all. Approve the second, and then you have the longitudinal strain graph in this patient. So by just placing these points, so this is circumferential strain. Immediately this is available, and go to end systole, you will get the point. This is the GLS which you have. This is GLS is -20. This is circumferential strain. This is -21, and you can have the area strain. This is area strain -35, and this is the radial strain which is +64. And you can have the rotation also. You can see here the rotation twist and torsion. This is the rotation, and this is the torsion which is available. And for longitudinal strain, one of the advantages that this bullseye plot can be made dynamic. So when you run that, this is a dynamic strain bullseye. This is not possible with the 2D echocardiography. Now you have got all the measurements which are possible with this technique. So that is about the quantification and chamber assessment. Now I will just show you something about the valves. This is the mitral valve, is one of the most important valve which can be assessed by 2D echocardiography, I mean 3D and 4D echocardiography. And the uses, this is the uses, and you can see here the main use is in the mitral valve assessment. And main assessment comes in mitral regurgitation assessment. And you can see here, this is the mitral regurgitation. So same thing, and this is a mitral regurgitation patient who can be quantified by 2D as well as 3D. This is a comparison of 2D versus 3D. This is the triplane view which you have, and this is the mitral valve apparatus as seen from the RV side, from the apex. So this is the normal view which you see in the short axis in 2D also. But in 3D, you have the advantage is that you can see also from the left atrial side. This is the what you see from the left atrial side. And here, you don't see this cardiac tendon attachment. You can see here the cardiac tendon attachments which are seen here, which is not seen here. It is very smooth. And otherwise, you see the aorta, a piece of aorta also. And this is AML and this is PML. So it's very easy. Assessment is easy. And assessment of the subvalvular apparatus is possible by this coronal plane cut. And most important advancement is that you can see in the mitral valve very clearly in the transesophageal echocardiography. So in 2D, you have multiple planes which are required to study the various scallops. You can see here the scallops in apical long axis or 120 degrees. You may be sure that this is A2 and this is P2. But still, you see, if you change the direction of the cut, see this is the direction 120 degrees. If you slightly move this side or that side, the scallops may change. So it's very difficult to understand which scallop is prolapsing by this 2D technique. Whereas when you go for the 3D, it will be very easy. So this is the 3D echocardiography cut, and you can see here this is the aorta. So always rotate and keep the aorta at 12 o'clock position. And here you will see the left atrial appendage in the 9 o'clock position. And from lateral side to medial side, this is A1, A2, A3, and this is P1, P2, and P3. You can see here the P2 is prolapsing. And there is slight prolapse in A2 also, but this is very easy with 3D echocardiography, whereas in 2D echocardiography, the prolapse scallop labeling may be difficult. This is the 3D anatomy as represented by the software, which shows you the prolapse of the P2, which is very easily done. This is the prevalence of a variation, various etiologies of mitral regurgitation. This is the most common is still in our country is the rheumatic. The males outnumber, male cause for mitral regurgitation outnumber the females, and totally it goes up to 41%, whereas the degenerative or mitral valve prolapse and myxomatous degeneration are only 40%. Where this is not true in Western countries, where they have a degenerative pattern ranking 61% and rheumatic only 14%. So MR, you have the Carpenter's functional classification. Type 1 is normal motion. It may be due to annular dilatation, annular deformation, which can happen in ischemic heart disease as well as ischemic cardiomyopathy, and perforation in endocarditis and clefts in congenital pathology. So that is type 1. And type 2 is excess motion which can happen with the myxomatous degeneration, and more commonly seen in degenerative disease like fibroelastic deficiency, Marfan syndrome, and Barlow syndrome. And type 3A is restricted motion. Restricted motion you can have. This occurs in rheumatic heart disease. Thickening of the leaflets, retraction, and thickening of the chordae. All these things are characteristic features of rheumatic etiology. Restrictive motion, apical displacement only. This is type 3B. This may be due to the tethering of the leaflets and papillary muscle dysfunction. And this happens usually in coronary artery disease may happen in inferior wall infarction or ischemic heart disease due to the so this is the form of frustry as well as the fibrous dysplasia. In Borrelio's disease, you have the prolapse of all the scallops. So assessment of the mitral regurgitation by color flow mapping is a common way, and we can see here the MR quantification is mild, moderate, and severe just by comparison of the color area and the LA area. That is mild, moderate, and severe. Can be also classed into early and mid systole and late systole. And 3D comes in assessment, and it is very easy 3D assessment. The vena contracta width can be measured very easily. And what is the advantage of 3D is calculation of anatomic regurgitant orifice area. I will demonstrate one of the cases for you. And 3D color Doppler stroke volume can be assessed very easily. And as you know, the PISA is not a regular heavy sphere. So that has been challenged only by assessment by 3D. 3D shows this is the PISA is not uniformly hemisphere. It is very irregular. And 3D vena contracta measurements you can have. So this is the anatomical. So this transverse line can be placed in the exact neck of the area. So that is the PISA head. This is the vena contracta, and then you have got the regurgitant area. So this can be measured in 3D by what is the technique which is called as anatomical regurgitant orifice area, which I will show you in a different case. This is measurement of this anatomical orifice. So you can just measure this just like your planimetry. It's very easy. So this measurement can be done, quantification can be done. So MR severity by left atrial size, LV size, pulmonary artery systolic pressure, and anticillary testings. And the most important factor to diagnose is whether it is primary or secondary. Primary is always valvular and requires a surgery. So this is one case of rheumatic mitral regurgitation, and you see the eccentric jet due to the caudal rupture. So there is an update which has been published very recently, and when you diagnose mitral regurgitation by transthoracic echocardiography by a clinical cardiologist, it has to be referred to an imaging expert. It's very important to diagnose whether it is a primary, secondary, or it is mixed. So the Carpenter's classification comes here, and the main assessment is by anatomic regurgitant orifice area, regurgitant volume, and regurgitant fraction. Associated findings include the LV size and other things. So now you can see here, this is normal type 1 normal motion of the valve, and abnormal leaflets, then it is primary. If it is abnormal leaflets, it becomes primary. Whereas when the leaflets are normal, it is due to the secondary cause. Secondary cause is more difficult to see. This routine evaluation of mitral regurgitation by all these quantification techniques have to be followed. That is the vena contracta width and the vena contracta area and other things can be measured. And then you can quantify whether it is a severe MR or mild MR. So mild MR or severe MR, you can do that, and it's very easy to assess by this technique. And then you go for the management pattern for these patients. So whether it is if it is a primary, patient is submitted for surgery. If it is a secondary, the patient you have to assess in a different fashion. If the patient has multiple risks, then he can go for the transcatheter mitral valve reparative procedures. So symptoms for secondary MR, again, revascularization. The main problem will be revascularization if it is due to the coronary artery disease, and if the patient is susceptible, suitable candidate for primary PCI, PCI or CABG, he has to undergo that. If he is not a candidate for that, then ongoing heart failure symptoms are persistent, he has to assess for CRT, and then the transcutaneous mitral valve therapies can be advocated for these patients. So this is the primary MR. You can see here the durable surgical repair likely if there is only one scallop is involved. You can see here in end phase view. You can see this is A1, A2, A3. This is P1, P2, P3, and only P2 is involved. So this is a very good candidate for surgery. And so when there is multiple scallops which are involved, you can see here A2, A3, and P2, P3 also. Still the repair is possible, but it is very some more difficult. And the only objection is when you have calcification, when you have multiple calcification sites, you can see here in 3D. So it becomes a difficult job for the surgeon. So these are the pathologies which you can select based on the 2D echocardiographic techniques, and the indication for surgery can be planned. This is a transcatheter edge-to-edge mitral valve repair can be planned according to the selection by 3D echocardiography. So these are the favorable and unfavorable management plans. So this is the patient, one patient I will show you. This is a patient with rheumatic MR. There is caudal shortening, tethering and pulling and preventing the coaptation. That is a point which you can see here. So this is the 3D long axis. And what you have to do is the anatomical M mode. See, end systolic volume, end systolic dimension has to be measured. End systolic dimension here is 3.8. The standard surgical indication is 4. So this patient is progressing, and this is the ejection fraction, which is around 56. When there is an ejection fraction less than 60, that is an indication for surgery. So this is a triplane vein, and this is, you see, this is the mitral regurgitation jet, which is seen in this is the 4-chamber plane, and this is the 2-chamber plane. This is called as a biplane view, and you can see the PISA head, which is the PISA head, and the PISA radius is 0.6, which is very much abnormal. This vena contracta width can be measured here. This is 0.5 and 0.4. This is the 2-chamber plane. This is the 4-chamber plane. It measures differently, the venous contracta. And this is the anatomical regurgitant orifice area, which you can see here. The anatomical regurgitant orifice area is 1.1, clearly abnormal. So 3D helps you in identification of this. And for recording the valvular anatomy, you have to use this software, mitral valve quantification software, where you have to align views first and then set landmarks. For this is the posterior annular border, this is the anterior border, this is a coaptation point, this is the aortic anterior wall. Only these points are required, and then you have the projection in this. So here you can adjust these points. These points can be adjusted, and then you have the software derived the mitral valve apparatus software data, which can be projected. You can see here, you can have all the data, the annular area, the tenting height. Tenting height is more than 1, indicates a surgical indication. Tenting area can be determined. So all these things can be determined very easily by the This is strain. This is a calculation of the 3D strain in this patient. You can see here the longitudinal strain, circumferential strain, area strain, radial strain, and twist. All these dynamics are possible in the same patient. So the basal rotation can be diagnosed from this patient. So that is how you can quantify the mitral regurgitation. And in mitral stenosis also, it's very easy. This is the 3D mitral stenosis. You can see here. The valve is markedly thick, and you can stop it exactly in the diastole, and you can measure the mitral valve area. The quantification software can be used, and the mitral valve area can be quantified very easily. So the other use is the interventional cardiology. In interventional cardiology, it can be used. This is used for mitral balloon valvuloplasty. The TE probe is applied, and you can see here the in our balloon, and you can see the opening and other things very easily. Mitral, this is one of the percutaneous mitral valve reparative procedures. And paravalvular leak, you can see here the paravalvular leak, which can be seen here. This can be closed by the intervention by using the 3D procedures. And the mitral clip, this is the mitral clip procedure which can be done for secondary MR, which I was telling. And this is the position and orientation of the clip can be controlled. And you can see here in real life. And this is the fusion imaging, where you can see the clip can be applied over that, can be controlled, and the alpha switch is placed. This is our famous Dr. Saibalkar. Saibalkar is doing mitral clip. He is our PGI. Now he is in yes, and he is a very expert. He did this procedure, mitral clip procedure, for our Echo India, which was held in Madurai. It was recorded during that. This is a clip being applied, and he is doing this procedure. This is also used for patients in valve-in-valve. So I will show you a case. What case? Just to show you a patient who had this is one of my patients who had who sustained an infarction some 35 years back. Just when I finished my DM cardiology, he came for my review, and he had hypercholesteremia. Just advised him the statins. He didn't take at that time. He landed up in severe problems, and he developed a myocardial infarction. He went around, had a cardiac arrest, and then went for primary PCI, and so this is the patient, and this patient has a severe mitral regurgitation. This patient had went in for dilated cardiomyopathy, and this is the mitral regurgitation. Are you able to see the mitral regurgitation here? Gross mitral regurgitation. So gross mitral regurgitation, and I will show you in 3D how to calculate the. This is the 3D mitral regurgitation. So now you have got this left-hand side. You have got the MR quantification software which is required for this. This is the cutting plane. This is called as transverse line or cutting plane. And the first, when you want to do these things, first thing is stop it in systole, and then you can go for a procedure. So first aliasing you can stop. So you can stop that. And then you have to reduce the baseline. See that this is baseline can be reduced. You see that the baseline has to be reduced to 37%, 32, 33 to 37. This has to be reduced first. Then the transverse line, this line can be reduced to the neck. You can see here, this is the neck, and you have to place it exactly at the vena contracta. This is the vena contracta. And the tissue can be removed. See that tissue? I'm removing the tissue. Just like that. You see that? This is the advantage of the 3D. You do everything offhand. I'm not having any patient now. I'm examining offhand, and you can see here this plane can be rotated so that the cut can be exactly perpendicular to your narrowest neck portion. So this is the pizza head, this is the neck, and you are having this cut area. So you can zoom in, you can zoom this, you zoom that, and then you measure the area. So this is the area in the crop plane. So you see that as simple. So you start that and you do just the planimetry. And you got that. You see that it is 2.8 cm square. So it's grossly abnormal, grossly abnormal. I have never seen just this. So we were planning CRTD for this patient, but before that the patient expired. So this gross MR, grossly dilated LA volume I showed you in the previous this thing. LA strain was 7, LA volume was more than 100 ml. So this is a gross torrential mitral regurgitation jet which required the intervention. Just that is 35 years after the primary PCI for this patient. This patient died recently. My close friend, businessman who died. So these are the important steps in 3D echocardiography which I wanted to show you. And one more thing, if I have time, I will show you the. I think we are running out of time. We will have some time for discussion and then close this session. Dr. Parale ji, I will stop sharing.
Don't worry, sir.
So I have stopped sharing, and now you can ask some questions regarding this. What is your workload and how many cases you do 3D echo, UPC? Because you are an imaging specialist, and I don't know how many % of the cases you do the 3D echo.
With the current 1 minute, I can. Can you hear me?
Yes.
All right. I think with the current scenario,
Yes, sir.
because when I bought that equipment, I have not bought a 2D probe. I have bought only the 3D probe for a cardiac work. So I have only 3 probes, and all 3 are volume probes or a 3D probe. So now I have a distinct advantage that when I start a patient, so it's just a click of a button. I don't have to change the probe. I don't have to do anything. Just click the button and you are in 3D. So I'm doing 3D in 100%, all patients.
That is
unless you have a poor echo window, well, both 2D and 3D are bad. So the 3D on what we have a live 3D, that is in almost every patient. And before this COVID situation, I used to do ejection fraction with that heart model. And that is something which is very good because a lot of AI has gone into that. What you do is that you just acquire a loop and say heart model. That's it. You don't have to tell which is LV, which is RV, which is LA, which is aorta, nothing. You don't have to say diastole, systole, nothing. So it takes precisely about 12 to 14 seconds, and it'll give you LA volume, LV volumes, ejection fraction, LV mass. Now we have an RV volumes as well included in that. So I think that is the strength, the ease of doing ejection fraction, the ease of doing it. It's far easier than to do in a Simpson method. So why should I use a Simpson method, which takes about 30 seconds, 40 seconds, where ejection fraction takes by heart model less than 15 seconds. So I think the paradigm would shift gradually. Initially, there was a lot of inertia of changing the probe, even if it takes a few seconds from your setting to select a different probe. There was a kind of an inertia, I must be honest. We never used to do it unless it's necessary, because the large volume centers, you get into trouble. Patients are already shouting, and once you're using a 3D probe, I mean, it's so easy. You don't have to press too many clicks to get into the different probe.
That is why you must have a separate imaging specialist like you. You have a lot of time for imaging. Unlike Dr. Parale, who is always active in cath lab, and most of the time he spends in my cath lab.
Yeah.
Okay, but I do 3D for all the patients, all my patients.
All patients, yeah, all patients.
And, it's very easy, and I combine that.
Amuthan's audio is not audible.
No,
I'm
it
not
is.
audible?
No, I'm not
No,
able to
it
hear.
is.
I'm
It
able
is.
to
I
hear
think.
UP, but I'm not able to hear Amuthan.
No, that is probably selective this thing, but I
Hearing
think
them.
we can selective definitions, whatever I call for Amuthan, but we can hear.
No, I very much want to
There's
hear
some
Amuthan
issue.
today.
No, there's some issue with the software actually. I did not hear. I could not actually see the video. But I think I double clicked that and I could see it. It is some issue. Yeah, Dr. Shah.
Dr. UP Singh, you are the dedicated now echocardiography.
Yes, sir.
You have been very active during this COVID period also, because a lot of
Yes, sir.
wars were going on. I have attended.
Yes, sir. Yes, sir.
So it may not be possible for every cardiologist, because you are a dedicated one.
Correct.
So it may not be possible with every cardiologist to do like that.
I have a small point, sir. There was a time when very few machines used to give you harmonic imaging.
Right. Yes.
And there was a time when very few machines would give you 3D. Now, I think even basic machines give you harmonic and 3D.
Yes, harmonic.
And next machine, I'm pretty sure what you're going to buy, you would buy a 3D probe which would work as that. And this is just a few months or a year ahead, sir. It's not very far. So almost everybody is going to do it. I mean, only that, we are riding the tide right now. And, because you are doing a multi system thing. So, I mean, it might take little longer on your side.
Yes,
but it would come. It certainly would come. So there is something which certainly would come.
Saji, when I retired, I get a bulk amount, I spent a whole amount on 3D echocardiography. And I don't have any regret for that. You see, I have spent the money and I have got all the money back. It is money back.
But it also you are interested in doing this thing. In fact, I have gone through your book 3D echocardiography also.
During my service time, also I did a lot of 3D. And even before joining PGI, I was doing echo. That is why Parale used to hurt me.
Parale is busy with interventions.
He is always an interventional cardiologist. Yes. And
interests do differ. We cannot say these interventions.
Yes.
It depends on.
I do everything. For my patient, I do the consultation. I do the echocardiography. Then do the angiogram. I do the angioplasty, primary angioplasty. I showed you the case. I did the angioplasty for that patient. So it is a total care for me. It's just like that. I go to a different hospital for intervention. It is how I.
Sumit, do we have any questions from the chat box?
No, sir. No questions. But before we sign off, sir, I'll let RS Meena. He has got a DM cardiology seat to his institution. And Dr. Asif Hassan also said he has also got 2 DM seats for Aligarh Muslim University.
Yes.
Though we also applied for that, but I did not have an associate professor with me. So I had just myself as professor and one of my junior assistant. So maybe by next time, one of the students that come out from Dr. Meena's college would join us, and we'll have that seat also.
We have Professor Emeritus Dr. Amuthan. Dr. Amuthan as a Professor Emeritus, you can always.
So if he can join us, it would be we'll have a great echo program also here.
Yes, we should plan one after this corona age.
Yes, sir, definitely. In fact, I had invited 2 great experts here also, and we had to cut down the meeting. It was 2-day meeting on echocardiography. So we had to cut down it because the corona thing had come, and then we could not have a public gathering by government orders. So we had a 1-day session which was somehow get it done, but second day we had to withdraw. So after corona things, sir, we'll have a here And in alumni group also, sir, we can plan a meeting anywhere whenever you stay.
The plan was to have this meeting in Chandigarh, and UPC was to be the host.
I'm planning, sir, already in March 2021. We would have a virtual meeting in case COVID still hangs around.
What happened to your ICC meeting in Chandigarh?
ICC, I don't know. I don't think so. It happened. Did it? No, there's no.
It is not happening, sir.
Yeah. Is it going to happen next year?
So, in fact,
in Chandigarh?
Sir, next year is too far. This time I had deposited money with Dr. Hajra for ICC meeting. So just 7 days back, he returned my money. So I think it is not going to take place this year.
So it will happen next year, or what are you going to do, UPC?
Yeah, next year, I think by February, March, we would do at least an ECHO virtual conference. And that I think that's a very good platform. I really like, I attended ASC virtual, and today I'm attending that ESC. ESC is there from, today until 2nd. Fabulous, you can actually simultaneously attend multiple halls virtually. The ESC meeting is really very good. I have just attended today.
Yes. And last year's Echo Chandigarh was very good last year.
Yeah, I think that was the last medical conference happened before COVID struck.
Echo, you should